The end-of-life choices that we have. And to do that, we have to get the word out that we have these meetings. And we also have speakers, and we have a newsletter, and we try to tell people what is new or what is old in end-of-life options. We believe that people should have the kind of death they want, consistent with their own values and beliefs. And sometimes, in order to achieve a peaceful death, one needs assistance in dying. And that's why we're having a meeting on this important law tonight and its future. So many things I want to say about that, but I think our panel and our guests will talk about it. I want to tell you that the Hemlock Society has been around now in its 31st year, again, trying to educate the San Diego community about end-of-life options. It's a membership organization, it's a 501c3. If you join, you get our newsletter. You can put your name on our email list and get notification about our meetings, which are every month. On alternate months, alternate to this one, that's the even months, we do a Right to Die film festival, in which you're all invited. We usually almost always meet on the third Sunday at 1:30, so our next meeting will be a film called Ikuru, a very famous Japanese film by director Kurosawa, at the Mission Valley Library. And then in July, our meeting is planned to talk about what you should know about hospice and palliative care. This is a very good option for many people, but a lot of people have serious questions about what it can do and what it can't do, and its attitude or their attitude toward the End-of-Life Option Act. So today we're talking about the End-of-Life Option Act we'll talk about this later during the rally in detail, but from my sources, legal sources, from Compassionate Choices, from legal professors around the country, what I understand is there is an appeal that has been filed by the Attorney General of California, most likely to be granted, and if so, the appeal process could last years. And if for some reason it's not granted, it's recommended that if you have started the process of the End-of-Life Option Act, that you get your prescription filled now. And Bob may want to say something about this later. We also think that during the pendency of the appeal, the act will still be in operation. So that's what we think, but none of us are prophets, so we're not exactly sure. And I think many of you are here because we're protesting this ridiculous, outrageous legal decision by this Riverside judge, pressured by people who are anti-choice, who want us for some reason to suffer at the end of life. I guess because it's ennobling. I don't know what the reason is, but it's not a valid reason. The End-of-Life Option Act, even though we've been critical of it here because it's very restrictive, has been passed now in 6 jurisdictions, plus the District of Columbia. And of course, California is the largest state that it's operating in, and so that's why we're a very good target. And I have to tell you that the opposition is not just to repeal the End-of-Life Option Act. They want to take us back to before there were advance directives, before we had the right to refuse treatment, before we had the right to refuse food and hydration. These rights are hard fought. I can give you the chronology of each one of them. We've been doing this since 1976, trying to get more and more legal rights so that people can die peacefully at their own choice. So be vigilant. And the best way to do that, I think, is to support Right to Die organizations and tell people that you are in favor of this, even if you have to argue with them a bit. In the back there, the Hemlock Society believes in telling you everything we know about how to die peacefully. That doesn't just include the End-of-Life Option Act. It includes what's going on in Switzerland. It includes refusal of food and hydration. It includes a lot of other things that we have programs on, that we've had programs on, that we have resources about in the back. So that's why our next meeting will be on palliative care and hospice. You should know about that. We'll talk about voluntary stopping eating and drinking. We'll talk about going to Switzerland to get help in dying. We are not limited to one model of achieving a peaceful death, which no other organization can say that, I have to say. In the back are books, pamphlets, our own pamphlet about achieving a peaceful death that you can make a donation and take home with you so you can learn more about your choices. What else do I have to say? Okay. I think with that, I'm about to have the great pleasure of introducing our speakers, and I have to cheat and look at the, I've printed this out 5 times, but I can't find it, so I'm going to tell you. When you get old, these things happen. So, today we have the pleasure of hearing from Integrated MD Care, founded and headed by Dr. Bob Uslander, and whose idea it was, by the way, to have the rally at the end of this meeting, so we're going to do that too. Okay. And Elizabeth Semenova, who is fortunately on our board and who works with Dr. Bob. And I have a complete description of this here. I could say on my own who I think he is and who they are.
Maybe you should just do that. You want to do
No,
that?
I won't. No. Dr. Bob Uslander is a physician of 30 years and the founder and director of Integrated MD Care, a private practice offering comprehensive, personalized medical care to individuals living with serious and terminal illnesses. The foundation of his work is fostering deep connections with patients and their loved ones as he guides them through major life transitions and facilitates their sense of peace and well-being, even in the most challenging times. Pretty impressive, huh? In the 2 years since the passage of the End of Life Option Act, which will be June 9th, exactly 2 years, Bob has encountered a great unfulfilled need to serve those seeking to achieve a dignified death. And one thing about this law, I'm now diverging from the script here, is access. This permits physicians to prescribe life-ending drugs, but it's very hard to find physicians who will do this. And that's why we're so grateful to Dr. Bob. His medical expertise, extraordinary compassion, and personal experiences witnessing the suffering of loved ones at the end of life inform and inspire his commitment to supporting people through the process of aging and dying. He joins us today to share his experience developing and facilitating the processes that have made him Southern California's end-of-life option expert. And that's true. If you look for somebody to help you die in Southern California, his name turns up. And maybe the only name that turns up. Now, Elizabeth Semenova over here to my right is the practice director for Integrated MD Care. Prior to assuming this position, she served as a hospice social worker, supporting patients and families through their end-of-life journeys. Elizabeth is passionate about ensuring that physicians and families are well comforted and fully informed about their care and their options. She goes to extraordinary lengths to support the patients and families under her care. It is hard to imagine that there is another individual as familiar and informed about the California End-of-Life Option Act as Elizabeth. She is a fierce advocate for patient autonomy and dignity and has partnered with Dr. Bob to support many terminally ill people throughout Southern California in having a truly peaceful and dignified death utilizing the End-of-Life Option Act. An additional person on our panel today is Jill Lloyd, over here on our extreme right. We don't have any extreme right people, do we? Just talking about her position here. By the way, extreme right people die too, and so many of them actually do support this law. Jill came all the way down from Orange County because of a call we had to ask people who have experience with the End-of-Life Option Act. And Jill will talk about her experience with a friend who had pancreatic cancer using Kaiser as their vehicle to use the End-of-Life Option Act. We're very happy that you came here, Jill. And so after this meeting is over, Bob will organize a rally And
I think we're going to stay here and rally. So
okay, stay here and rally. There's going to be in the parking
there might
lot.
be some other people coming in, but so we might have to share the space. But
Yeah.
we won't let the party break up so soon.
Okay. And at the rally will be speaking, among other people, Debbie Ziegler, whose daughter, Brittany Maynard, was the person who got the End-of-Life Option Act by going to Oregon to use the Death with Dignity Act there. Debbie, wherever you are, I am very glad you're here. If anybody deserves to be here and to talk to you, it's Debbie Ziegler. So now, Bob, it's your mic.
Thank you, Faye. Thanks everybody for coming here on a Sunday. Lots of other options of things you could be doing today. So we're getting started a little bit later, so we're going to compress our program a little bit. I hope that's okay. Just by a show, so thank you for that. I wasn't expecting to be applauded. That was by a show of hands, how many people in the audience actually have been a patient, have we worked with through our practice in some capacity? Okay, there's a handful. Got it. So the rest of you don't really know much about what we do, but I understand that you're here to learn about the realities of the End-of-Life Option Act. This talk was scheduled months ago so that we could talk about the law, the how-tos, the ins and outs, the realities of it, the challenges. And then, of course, this past week, everything sort of got much more interesting, right? One way of saying it. If anybody in the room is not aware, last Tuesday, a judge in Riverside County overturned the End-of-Life Option Act on a technicality, claiming that it was passed unconstitutionally because it was done so in a special congressional session on, of all things, healthcare. So apparently, how you the options that are available to you and how your life ends is not a healthcare issue. So as Faye said, we don't exactly know where things are heading. It's a very concerning time for many people. And I can share a little bit about what some of the struggles. Elizabeth and I have been on the phone almost nonstop over the past 5 days, talking with family members and patients who have already initiated the process and trying to figure out what that means for them. So we can talk about that. And I think I'll save some of those comments and that discussion for the rally afterwards. But I want to so I'm going to use this time to talk about the specifics of the law, how somebody takes advantage of it, some of the barriers that we've discovered along the way, and then we'll hear from some of the family members who have supported their loved ones through it because they have their own unique perspective that everybody should hear. So just as just to start out, can I see a show of hands for who in the room does not plan to die ever?
Just volunteer back there.
All right, so we have one. Everyone want to get to know him. All right. So I think we're pretty clear on what our ultimate. We share this. We have two things in common. We were born, and we will die. And there is a lot of angst and anxiety and distress that comes along with trying to deny that fact. You can't deny that you were born. Some people are living and acting as if they do not believe they will die. And most of the time, that doesn't serve them well. It doesn't serve them well, it does not serve their families well. Because the only way to avoid a lot of the struggle and the horrific dramas that unfold is to be prepared and to plan for it. And I think Elizabeth and I can share, since we started our practice, which is a unique model where we get very intimately involved with people through the last stages of life. Sometimes they're patients of ours for months or years, sometimes for hours or days. But of the hundreds of people that have died under our care, I can think of one who struggled in the last hours and days of life. There is a way to avoid the struggle, but it really requires preparation and planning and being willing to look ahead I like to say we have to start with the end in mind. If you start with the end in mind, if you understand how you want to ultimately die, assuming in fact that you will one day, if you can look at that and understand what your values are, what's important to you, what you want to happen, to be happening, if you could orchestrate it, and then it's just a matter of putting the things in place upstream. And you can do that, but it does require some planning. So let's talk about the actual law so that everyone understands the details. And I would encourage you to step in anytime, because you know it even better than I do. Truly, Elizabeth is the expert. She has pored over the law. She is in the thick of it. And so if there's ever any questions, she really is the person who we should be relying on for the answers. So, the End of Life Option Act passed in October of 2015, signed into law by Governor Brown, took effect June 9th, 2016. Basically, it's mirrored after the Death with Dignity law in Oregon, and the law is very similar in Washington State. A competent adult who's a resident of California with a terminal illness can request a prescription for lethal medication from an attending physician. If they get through the process, and I'm going to lay out the process, if they get through the process, that physician is able to send a prescription for currently one of 2 different medications to a pharmacy, a participating pharmacy. The patient can access that prescription when they want, if they want. So here's how it goes. John Doe makes the request of me or their attending physician on May 1st. We have a visit. Most of the time we go to visit our patients. We go to see them at home because they're already struggling. We don't want them to have to struggle further to come into my office. We go and we have a visit with them. We get to know them. We understand who they are, where they've been. Most of the time, for the first half hour, 45 minutes, it's just like we're having a conversation, getting to know each other. During that conversation, we learn about the patient's condition, we learn about their history, and we understand what they're looking for. We lay out all the options as well. We talk about all the possibilities of how you can have the most peaceful, comfortable end-of-life experience. We don't just talk about the End of Life Option Act, we talk about all the possibilities for palliative care and hospice care and comfort medications and palliative sedation, and we talk about the possibility of treating the condition, if that seems to make sense. If the patient is looking to go forward with this option, and it is just an option, they're not making any commitment, they make a verbal request to me in private. I have to determine that the patient's competent, meaning that they understand the impact of what they're asking, they understand the consequences of what they're asking, and it's on me, the attending physician, to determine that their condition is terminal, meaning that it's reasonable to conclude that their condition will end their life within 6 months if it runs its natural course. Sometimes that can be a bit of a challenge. It's not always straightforward, and it requires some investigation, collaboration with their treating physicians, reviewing records, things along like that. That initiates the process, that initial request, one-on-one request. The patient then needs to make a second face-to-face request to the attending physician after 15 days. It doesn't have to be 15 days, but it can't be any sooner than 15 days. It can be 20 days, 30 days, 40 days, but no sooner than 15 days. It's the cooling off period. I can talk about my thoughts about the 15-day waiting period, but I'll do that later. So the 2 verbal requests to the attending physician in private, each time the patient has to be competent to make that request. The patient has to sign a written request form that basically says, I, John Doe, am suffering from terminal cancer, if that's the case, and I'm requesting, there's a lot of verbiage in there, but it's essentially the same thing as a verbal request, just in written form. They sign and date the form, and it has to be witnessed by 2 people. One of those people can be related to the patient or a beneficiary of their estate. The other has to be, the other can't be. It has to be a friend or a neighbor or some uninterested person. I'll answer questions in a bit. Hold on to it though. So the witnessing of the written request, it really doesn't even require that the witnesses know what they're signing. They just need to be able to state this person is competent to be signing this, and of course they're not doctors or lawyers, so they just have to believe that this person understands that they're signing this form. And like I said, they don't have to know that you're signing a form that is a request for a life-ending medication. You're not trying to trick people, but that is a little bit of a nuance. So they have to sign the written request form witnessed by 2 people, and a consulting physician, a second physician, needs to see the patient or have seen the patient recently and be willing to sign a consulting form that confirms that the patient's competent and that they have a terminal illness. The consulting physician can see the patient at any point. It doesn't have to be after the 15-day period, after the 2 attending physician visits. It can be before, during, or after. But it has to have happened within a reasonable time frame, so the consulting physician can still feel comfortable that the patient is still competent to make decisions. Once the 2 requests are made of the attending physician, separated by at least 15 days, the written request form is submitted and the consulting physician form is submitted. The attending physician can send a prescription to the pharmacy for the life-ending medication. Once the prescription goes to the pharmacy, it's on the patient to decide whether or not to have that prescription filled. They don't have to have it filled. At no point is there any obligation on the part of the patient. If they choose to have the prescription filled, they can have it filled and delivered to them, and they can keep it for essentially as long as they want. There's no obligation to take it once it's delivered. At no point is there any requirement or obligation on the part of the patient. Even after the medication is mixed, and each of the medications ends up being in a powder that gets mixed with water, so it's a liquid, even at that point, if the liquid is being held up to the patient, if the patient is holding the liquid up to their mouth, ready to drink it, they can stop this process and say, you know what, it's not time. I don't want to do it. The patient has to be able to ingest the medication on their own. Nobody can administer it for them. That's a big safeguard. There's many safeguards, I've already talked about a few, but the patient has to be able to ingest the medication. That doesn't mean that they have to be able to take a glass and hold it and swallow it. They can drink it through a straw. We have patients who are quadriplegic. They have multiple sclerosis or the ALS, and they can't physically hold a cup, but they can swallow, they can drink. So they can drink it through a straw. There are other patients who can't swallow. There's a lot of fear around what happens if I can't swallow, and especially if I can't swallow 4 or 5 ounces of liquid in the amount of time before it will take effect and you fall asleep. The patient can have the medication administered through a nasogastric tube. So any medical professional can put in a nasogastric tube, or some of the patients actually have gastric tubes. And the liquid medication can be put into a syringe that the patient then depresses the plunger of the syringe to push the medication through the tube. So nobody can do that, but that's the patient voluntarily bringing the medication into their system. Okay? Typically what happens, so there's 2 different medications, and you may have heard about the difference, and it's kind of appalling that one of the medications is exorbitantly expensive, but there are 2 that are currently being used. One is Seconal, Secobarbital. It's a barbiturate. It's a sleeping medication, very, very potent. It was used in the 60s, 70s as a sleep medication. It's off the market for that because there are safer alternatives, and I think there were probably a lot of overdoses. It was also out on the streets, sold recreationally as Reds or Downers. I have a patient's son who confirmed that he used to sell them for $1 a piece in the 60s. Interesting. Seconal comes in 100 capsules, 100 milligram capsules. The capsules need to be opened, each one, and the powder collected and then mixed with liquid. The patient does not have to open the capsules. A family member or a friend, anybody else, anybody can open the capsules. There's no specific requirements. It gets mixed with 4 to 5 ounces of water and then consumed. The other, Seconal currently costs about $3,700 for a prescription. My understanding is that the day that right around the time that the law passed in California, the company that manufactures Valiant Pharmaceuticals up in Canada doubled the price. So that's a challenge. The other medication is called DDMP2, and it's a combination of morphine, diazepam, digoxin, and propranolol. Medication to make you sleep, medication to stop the breathing, and medications that are toxic to the heart. It comes in a powder form, put together by a pharmacist. It gets mixed with water and consumed. That medication costs around $700 to $800. In my experience, Seconal is by far much faster, smoother. It's the drug of choice for achieving a peaceful and gentle death. Most of the time, people fall asleep in 3 to 4 minutes, and frequently they stop breathing and die within 20 to 30 minutes. Sometimes sooner, occasionally a little bit longer. But it's always, in my experience, it's been completely, the patient is unaware, they fall asleep, and it's gentle. And the loved ones are there relieved beyond descriptive, beyond any measure of imagination, that there is no struggle. And it's extremely peaceful. The DDMP2, most of the time patients fall asleep in 5 to 10 minutes, stay asleep. The death, it can happen within 30 to 60 minutes. There have been cases where it's delayed as long as 8 to 10 hours. I heard a case not last month that took 24 hours. So you can see why I typically will recommend to people that if they can, if the cost is not prohibitive or a huge disincentive, that they choose the more expensive option. But either way, both are 100% effective at this point. So the responsibility for the attending physician is to guide this process, to educate the patient, to help support the family, to answer any questions, to be as, again, informative and supportive as possible, which I think in many cases is hard for attending physicians who are doing this in the midst of their busy practices. There is no requirement that any medical professional be with the patient at the time when they take the medication. I've made it a practice to be with people when possible. So because I think that I've found that it's really valuable to have a knowledgeable, supportive presence there with the patient. Most of the time, the patient honestly is just ready, and they just want to get the party started and get on with things. It's the families who are really anxious and uncomfortable about what's going to happen, and any unusual movements or breathing patterns, or they just want to know that they're doing everything right. And so being there in that time is, I think it's important, and I think having had the conversations with family members and patients after the fact, I'm pretty convinced that it's really important. And it's really meaningful for me to know that things are done right and everything has gone as smoothly and gently as possible. And then we submit a whole bunch of paperwork. So that's the how-to. That's kind of the nuts and bolts of it. And so really important. With the law in place, if somebody goes through the End-of-Life Option Act through this legal process, the cause of death is the underlying illness. Whether it's ALS or cancer or end-stage heart disease or kidney disease, that's the cause of death on the death certificate. Life insurance is not affected, it's intact. At the beginning of all of this, as it was new, we found that it was really helpful for patients to be on hospice. Because when a patient is on hospice, when they die, it's just a smooth, the hospice people come in and the process goes, very smoothly. There's no need to call the coroner, the medical examiner, and the mortuary or funeral home or crematorium can be contacted. When patients die when they're not on hospice, it can be a little trickier. And I think you wanted to speak to that, so I'm not going to steal your thunder on that, but we'll talk about it. As it's gone on, what we have learned a lot through the course of this. We have supported somewhere in the range of 110 to 120 people. Not all of them had gotten the prescription or taken it, but I think I've been with somewhere around 80 people who have taken the medication and died. And there have been some times when we got some surprises that we weren't anticipating, and it ended up becoming a challenge for the families. The patient got what they wanted. The patient is off, freed. I like to say that when they die, they're released. They're released from their struggle. They're released from this body that is no longer serving them. That they're on their way, and the families are universally relieved as well. But then there have been times when we just assumed everything was smooth and calls had been made, but the police showed up at the patient's door, at the family's door, because if they weren't on hospice, then they didn't know what to do. The mortuaries, the crematoriums, funeral homes didn't understand. We tried to prepare them and give them information, but they still, change of shift and somebody else comes on and they don't know what to do, so they call the coroner and they send out the police. Riverside County doesn't even matter if you're on hospice. They always report to the coroner. And so we have done a lot of educating of the medical examiners, the coroners, the funeral homes, the mortuaries, the hospice agencies, about this process and how to avoid having to, how to avoid the challenges. I mean, imagine everything, you've gone through this process, you've just said goodbye to your loved one, and now the police are showing up trying to make you prove that this was all above board. So those are the kinds, so let's talk about the barriers. How are we doing on time? Oh my goodness. I'm gonna let some of our folks here get up and take the mic now, because I want them to talk about what they experienced with some of the barriers, because I think that'll be more poignant. Can we do that? Yeah. Okay, and we will take questions. You have one question, I'll answer it now.
Yeah.
So he would have been able, if he could drink through his straw, the process probably could have happened.
Can you repeat the question?
The question was, his brother died of Lou Gehrig's disease, and at the time that he died, or leading up to it, he couldn't move, he had no function, he couldn't sign, but he still could swallow. But he was mentally competent, right?
Yes.
So, not being able to sign will not keep somebody from being able to enact this. We videotape their request. If there's a way to get a pen in the hand and make a scratch. We're here to protect the patients. We're here to protect the integrity of the law, but we're not here to punish people for having those physical limitations. So as long as he could bring the medication into his body in some way, he would be able to do this. Okay.
Lou Gehrig's disease, the last two things that go are your mind and your bodily function. No one carries you to the toilet.
Okay, we're good.
Can you stand?
You want to stand?
I can. I have your questions in front of me too, so I want to make sure I answer those. So Faye gave me some questions, so I can stand right here. I'm good. Are we all good? Yeah. Okay.
Say your name again, would you?
My name is Jill Lloyd. It's like Jack and Jill. It's an honor for me to be here. My friend who died in 2016, she was actually diagnosed on June 9th, 2016, and the same day the law became effective in California. And for her, she saw it as a blessing. We're children of the 60s and 70s. Her and I, we were friends for over 50 years. We fought for a lot of rights, went to a lot of protests early on, and continued to as other issues came up, gay rights, abortion rights, all of those things. And we talked about the law. We had a lot of friends and family members who suffered, and so it was a conversation that we've had. I've been a hospice volunteer for over 30 years as well, and I work in funeral service, so I'm kind of like that death and dying friend, I guess. But when she did get diagnosed and she contacted me, and I was, of course, devastated. She was the healthier person. Just, did everything right. So I thought, well, I'll change now. Anyway, so she was diagnosed with pancreatic cancer, found out very soon that there really wasn't going to be anything that they could do. And like Dr. Uslander said, you start at the end. And she was very organized, a person too. So that's how she started to look at it. What do I want my life to look like? Backwards and leading up to, where she was right now. So she was had already researched the process. We had been involved talking about the law when it was still going through all the different phases. So she really educated herself. So she knew what to do. She had a folder on it. And so right away when she went to meet with her doctor and got the diagnosis, she was with Kaiser in San Marcos, it was, and was very surprised they already had a patient navigator in place. They were kind of ready for it. And her doctor was very supportive. So she thought, wow, that's pretty easy. And it actually did move pretty easily and smoothly for her. She was able to find a second doctor through the help of the first doctor, the prescribing doctor, doing the paperwork and so forth. So that part of it went really well. And she really followed her symptoms. And her thing was, like Dr. Uslander said, she didn't want to go on hospice care. She had a little ranch out here, she had farm animals, she loved being active, she was still working, and she says, if I have to be in bed at all, I'm not sticking around. And I know that this disease, the way it progresses, it's going to challenge me in doing that. I know if my liver starts to fail, my brain can get fuzzy. I still want to be able to have the mental capacity to make decisions for myself. So she really carefully monitored her symptoms and so forth. And she did get the prescription, and they actually asked us to come because she asked me if I would be there with her. And another friend who were chosen, she chose us to come and be with her on her day of death, but she wanted us to go to the pharmacy because she said, these two are going to open all those capsules, so you have to tell them what to do. So it was a little daunting, but anyway, it was very interesting because they had the patient navigator there, and having been with hospice, I asked questions too because I was concerned. Like, who do we call? It's just going to be, the three of us, and then the two of us, so what do we do? Because we don't have a hospice support person there who to call. And so we worked out a plan with the patient navigator, and anyway, I think that's kind of where things fell off there. But anyway, I have some questions that Faye gave me, and I'm going to answer those, and that will tell you what happened next, actually. So, did she pay anything for her care and meds from Kaiser? And so on her plan, she only had to pay $30 for the meds. So that's pretty cool. Yeah. Good insurance. And most of her visits were very typical, and her care was covered, so it was not a costly thing for her, fortunately. Did she have to go through the navigator to find a doctor, or was it her own PCP? Actually, her oncologist that she had at Kaiser, like I said, was her prescribing MD, and referred her to another doctor who was the second opinion. And next question was, did it take long to get all the paperwork and second opinion done? Actually, no. After she waited to hear about some possible treatments, some curative, not really curative, but other treatments that she might be able to do to prolong her life. So she waited to get the final decision on that and then decided, okay, I'm not going to take any treatment. So that kind of delayed it. But once she knew that her cancer was progressing and was not operable or really treatable, she went to work on the paperwork. And did she use Seconal? Yes. And was she okay getting it down? Yes. And it was really quite surprising. I mean, opening the capsules it actually became kind of funny in a way because we made a joke of it. That just was our relationship and so forth. It's kind of a weird way to spend the last hour with your best friend, but she was so appreciative of us being there for her, and kept thanking us so much for doing this for her, because she said, you know, not many friends will do that. And I wanted to mention when I met Brittany's mom today, which is the first time, and we instantly connected, because if you've had somebody that's been through that, you get it and why you're here. And we were just chatting a little bit, and she talked about the comments from the bishop from the royal wedding and talking all about love and the power of love. And I liked what she said, because this really is all about love. And that's what you do for friends, or at least that's how I feel. And that's what keeps me going as well in doing this for her. But I think she also saw, and she talked to me a lot about it, she says, you know, because this was kind of easy for me, you know, just because of the other battles that we've had, this fight isn't over with. And I hope you'll use my story one day, you know, to educate and help other people. And we always saw hurdles as opportunities anyway, and that's what I see this as, and also an opportunity to educate people. So I feel like, and my friend's name is Gail, that I am using her story to do that. The other question was, so she did, yeah, how did it go down good? Actually, yes. I was trying to find a really nice glass to put it in and so forth, and she just grabbed the measuring cup and just drank, and just chugged it. And I said, what's it taste like? And she said, just kind of bitter, and then she chased it with wine, and we just were standing there talking, and she goes, I don't think this is gonna work. You know, and we were just standing up, and then I kind of saw her, so I said, let's swing a little bit, and I said, let's go lay down in the bedroom. We all lay down on the bed together, and she looked at Kathy, my other friend, and she says, thank you so much. I love you both. And that was it. Within 2 minutes, she was asleep, and she died about 12 minutes later. It was very smooth, and we were just like, wow, that was it. And it was, you know, I felt it as an honor. Of course, it was a sad situation, but I honored her wishes, and I really respected her choices and so forth. But that's kind of when the wheels fell off, because then we had to call the doctor, like we worked out with the patient navigator. We contacted her doctor before, 2 days before, which we were told to do. She said, I'll be available, and she wasn't. And she had donated her body to science care, so there's kind of a time frame with that. So we were scrambling around. I had to try, one of us was calling science care because we figured, oh, this is not gonna be a problem. And then we were trying to get a hold of her doctor. She wasn't available. We found out that she was out of town, so that really was very nerve-wracking. I won't drop any names, but I was very upset with her. And we finally got somebody there in her practice that was able to do it, and basically he just said, you know, we confirmed over the phone that she was dead. He asked me a couple questions, and that way, so when Science Care contacted them, you know, things would go okay. I have an email that she wrote to me when she was explaining to me after that patient navigator meeting to tell me, because she was very organized. So she said to me, as it stands now, I'm on clinic-based palliative care. My team is only available to me Monday through Friday during the day via telephone, not via home visit. If I choose to end life on a weekday, I would call up my team, give them a heads up, and call Dr. to give her a heads up. They would be the ones to call after I passed away to Science Care, which she donated her body to, would call them to get signature for death certificate. Coroner is not involved at all. One very important thing, in all caps, do not call 911. Okay. And so one thing that they asked me to was, why not hospice? And again, I think not knowing on the other end what we would be dealing with, even though it ended up working out okay, because we were very resourceful. It just was another personal choice for her, I think, and the idea of going on hospice. The day that she died, she got up, fed her animals, we had breakfast, we talked. It was like a normal day for her. Her idea of hospice just did not appeal to her. And so that was, you know, another choice that she wanted to make. But if anything can be learned from this, and I'm a hospice volunteer, and since then I have had patients that have accessed the law. It's a lot easier for everybody, the family left behind. So that would be, get on hospice care if you can, and that's, I would strongly suggest that. Kay wanted to know who I volunteer for, and I volunteer for Companion Hospice, And at first, the first year or so, they were not very supportive, and they have since changed that. And their medical director will now serve as the prescribing and will also assist in getting the second doctor, and that's just very recently. And I think what I also would like to stress too, so if you do go looking for a hospice, that you ask those important questions, if they will support your choice, if that is something that you want to do. I think that's very important to have a supportive hospice. There's a lot of them out there now, so I would encourage that as well. And one of the other questions was how long did she suffer before deciding to do it? And from the time she was diagnosed until she set her day to die, it was 3 months total. And did she have the Whipple surgery? No, she did not do that. So that's my story. So thank you for letting me tell it.
Thank you. So I guess the one take-home point here is if you think that you're likely to develop a terminal illness anytime soon, you might want to get on Kaiser now. Sometimes going through the system works, and I've actually heard a number of positive reports from Kaiser. Sometimes the system has challenges and can put up roadblocks, and I think Elizabeth was going to speak quickly because we're running out of time to an experience where somebody started going through the system with the doctors who had been taking care of them and ended up struggling as a result of that.
So I just want to share the story of one of our patients whose wife I spoke with. She is unable to be here because she's sick. Sorry. Sharing the story of a patient whose wife was unable to be here because she's sick today, but she asked me to share her story. They were in UCSD, and the patient she was young, and she had a very serious, very unusual condition and was certainly qualified. The doctors told them that they would be supportive and initiated the process with them. And over the course of the time that it took to get from one appointment to the next, from one attending physician request through the panel that they had to go through to review her case, it became clear that it was taking too long. And they actually came to us and initiated the process with us. And then the doctors and social workers told them that they would be able to speed it up, and so they went back to them. And then they found out that that was not the case, and they came back to us, and they said, do we have to start over? Is there anything you can do? Can you help us, please? And because they had initiated the process, the 15 days was almost up. We had their second visit, everything went very smoothly. And she was able to take the medicine and pass before it became impossible for her to do so. And her wife wanted to share with everyone the fact that with the support of our team outside the system, they were able to accomplish her wishes in a way that they wouldn't have been able to otherwise. So it's important, I think, to remember that the system can be really helpful. It can also have glitches, and that there are resources elsewhere that can be helpful in both navigating the system and in stepping outside of it to get done what it is that you need to get done.
Thank you. We're getting close to wanting to wind down. Just, are there, and we have a couple other people who wanted to share. I know that there are folks who want to speak about their experiences. And what I'd like to do is when we're going to stay together. Anyone who wants to remain here for the next hour and a half, we're going to have this rally, which is essentially to support our right to choose how to die and express our extreme displeasure, outrage, disgust with the recent developments. I know I want to hear from Debbie, and we have a couple other folks who wanted to share. But what I do want to put out there is if there are questions about, well, first of all, if there are questions in the audience, I want to take some questions. But if there are additional questions, if people are wanting to get information, whether you are looking at going down this path or not. There are unfortunately not enough really good resources. There's Compassionate Choices is a resource, and there are volunteers. Death with Dignity, Debbie can speak a little bit about that as well. She's on the board with Death with Dignity. I also want to offer us as a resource for having conversations that will help you know where to go to find the support that you're looking for. So you don't have to be a patient, you don't have to sign anything. We want, like I said, Elizabeth is passionate, we're all passionate about providing accurate information so people can know where to go to get the support they're looking for. We don't want anybody struggling and trying to figure this out on their own. So let me what I'll do is I'll take the questions. Oh, you have a microphone for questions? Great. All right. So we got 15 minutes for questions?
Yep.
Can you hand last side there? Okay.
Oh, John, thank you.
As far as legal requirements are concerned, what's the interaction between the Advanced Healthcare Directive and a process that you would put in writing to implement what you're speaking about?
The question is regarding advanced healthcare directives and how this process would kind of interplay with that. I'm assuming, well, that's a good question. In many cases, if you're going to go down this process and get access to the medication and are planning on taking it, then you would certainly want your advanced healthcare directive to reflect that you do not want any resuscitation, that you do not want any extraordinary measures, and you should have a POLST form completed as well that reflects this also. And that POLST is the physician order for life-sustaining treatment, is a legally binding document. And that supersedes any previous advanced healthcare directives. But it's really important that if you are going down this process, that you make sure that your healthcare agent, whoever is going to act on your behalf, if you are not able to communicate, understands exactly what you want and understands what you're doing. It would be a shame to have there be a conflict or lack of understanding. So I do think that it's imperative that the attending physician is able to review your documents and confirm that they are in alignment, and I think it's a good idea to create a new POLST if it doesn't reflect what you are wanting. Now, keep in mind that people may be getting access to this medication, they may be going through this process. About 50% of the people who are seeking the medication or keep seeking this prescription are looking to take it as quickly as possible. That's been our experience. They're dealing with something that's so challenging and they're declining quickly and they're ready to go. Many people would take the medication the first time we see them if they had access to it. But they obviously can't. They have to go through the 15-day period, and so many people are waiting for that 15th day to get out of their struggle. The other, I'd say 50% or so, are looking to get the medication as assurance that that when things change, that they will have this option available to them. So it may be that somebody gets the medication and they're not planning on taking it for a period of time, and their advanced healthcare directive may need to be created and then modified. So it's an interesting question, and I think it does need to be addressed each time.
Yes, because it sounds.
And it's nothing to do with the merits of assisted dying. It only has to do with the fact that the end-of-life option act was passed during a special session of the General Assembly having to do with healthcare matters only. That's the whole legal basis. Compassionate Choices does not think it's a strong case, so it's going to have to go through the courts and see. I just want to say that you cannot ask for aid in dying in your advance directive. Two different documents.
Any questions?
If the price of
I don't think that it's being sold currently in Mexico. People may be able to get it through sources in Asia. You always have to wonder what it is that you're getting because there's no regulations, and it's not legal. It's not a legal process. So some insurances are actually starting to cover Seconal. Medi-Cal covers it fully. Interesting. Some Medicare does not because it's a federal program, but there are a few some TRICARE policies, some Anthem Blue Cross policies. So each time we're looking to try to find ways to get as much of it covered as possible.
Why are there only 2 drugs available for this?
Good question.
Yeah, that is a good question, because not a whole lot of research has been done on it. And it has to be, there's certain requirements that need to be fulfilled. They need to be able to be ingested quickly. They need to take effect quickly. And there's not a lot of drugs out there that are so universally effective or fatal. And so that it's really important. You don't want people taking this medication thinking that they're going to end their life only to become, in a permanent vegetative state. So there is ongoing research with physicians and pharmacists who are collaborating to try to find better, lower cost options. It's a struggle, and that's one of the huge challenges that we deal with. So because we stay involved with them throughout, and one of the conversations that I often have with people when they either find out about the 15-day period or they're aware of it and they realize that they either may not last that long and be in a condition where they can ingest the medication on their own, or it's just each day is just so much struggle. So the other option for these people, as it is for anybody who's dealing with a challenging illness, is to stop eating and drinking and have increased support from the either hospice or palliative support network. So we'll let people know that if they can start the process, and if in 15 days, after 15 days, they're able to and want to have that second meeting, we'll do that. But there are people who say, I'm done, what can you do, let's get this, let's do this faster. If they stop eating and drinking with the appropriate support, it's not painful, it's actually fairly peaceful and relatively comfortable with good support. And most of the time people will be unconscious within 3 or 4 days, and usually they'll die within 8 to 12 days. But the patient themselves doesn't have to struggle a lot. It's not quite as comfortable for family members to go through that, but it is another option for people who can't wait 15 days. And I agree with you, 15 days is an interminably long amount of time. Elizabeth said that Belgium is the only country that allows minors to request physician aid and dying. Belgium. One day you will, and it could happen any day now.
I just want to say that this is a session on how to use the End of Life Option Act and a rally to support it. We have had many sessions in which I and other people have criticized the restrictiveness of the End of Life Option Act. We have looked at the law in Canada, which is much more liberal and takes care of some of these issues that you're raising now. Right now, we're very fortunate to have the End of Life Option Act. We do not want to see it go away, but it certainly could be improved, and many of you are raising those issues that would make it a much better law.
Sirs?
Yeah, I think those are state to state rules, and the polls should supersede any previous documents.
In California.
3 more questions. And then stick around and we'll have time for others.
Hi, everyone.
Hi.
Can you hear me without this?
No.
Okay. My questions really have some time.
Thank you. So I think the key here is stay tuned. we will know in a couple of days where things stand, and then we will all, have an opportunity to get engaged in the way that feels right, and hopefully we'll be able to provide more information. There's a lot of concerned people here who will be coming together to try to be as supportive and united as we can. I'm sure of that. 2 more questions?
Could you say something about the use of nitrogen, please?
No, I don't really know much about that, I'm sorry.
I do.
Faye could.
Yeah. Final Exit Network, a national nonprofit organization, recommends the nitrogen method to people who want to in their lives who meet the qualifications of the Final Exit Network. Our last meeting was a demonstration, I think our last meeting, anyway, a demonstration of the nitrogen method by a doctor from the Final Exit Network. We did not tape it. You can read about it, you can call Final Exit Network. There's some stuff about it on YouTube. It is another method.
I've had a small handful of patients who have. So I in the right circumstances, I do. It's one of the options that's discussed when we get together and talk about what people are looking for and what their challenges are. So B said Volunteer Stop Eating and Drinking is something that is a legal option for anybody. But as far as numbers, I probably supported 5 or 6 people through that during my career. But I anticipate that the numbers will grow.
Some of them were Hemlock members.
One last question.
Email that you want.
What do you want to do? You want to take a couple more questions? Do you want to get things moving along?
I would love people to get their